Hey, thank you all so much for your time and expertise today. We're going to take some time to answer our attendee questions. The first submitted question was, who should be having the conversations with family members as they prepare to make decisions about what can be brought into a room with a resident?
Mm. I can take that one. I think during the move-in process, it probably starts and depends on um, kind of what's happening with the resident and the family at the time that they're moving in. If there is opportunity to have some planning and a bit of conversation about it, and the ability to do some pre-assessment of the residents' fall risk status, that's helpful to know, and I think the staff then can have some of that conversation with them. I would say most likely what I typically, I guess, hear, and maybe Shirley, you have some other thoughts on this too. It typically tends to be either the executive director or the administrator of the community, or the director of nursing, or the head nurse that's a part of the community. That sometimes it's the sales director as well. Kind of depends on the situation, but I think being able to tailor a conversation that where you can help people think through what the needs might be. Sometimes they're out shopping for a brand new bed. They're having, they're trying to think through like what kind of chairs to bring in and how many pictures do we bring in and all these sorts of things. And starting slow, I think maybe coming with the basics and then kind of figuring out as we go are some of the more common things that I probably have either seen or have heard providers do. Shirley, do you have any thoughts on that?
Yeah, we actually developed a move-in checklist to help our communities out, which is actually also on our fall resource hub that we have on our website, where you can download. But it's basically a checklist that we would recommend to actually send the families before moving in. It gives them at least some idea of what type of furniture they might want to consider bringing in. We also really advise sending them actually the floor plan and the measurements, right? Just as any of us, when we move into a new place, we always take the measurements and will my bed even fit, right? And so and we've actually advised if there's a way for you to like even do it with them and actually say, hey, what size do you have a twin bed, and actually design it before actually moving in, and that would actually give you a lot more insight into what actually should they be bringing in. But we do provide kind of the quick kind of checklist of what makes sense, and so you can manage that before that moving truck kind of happens. And unfortunately you're going to have to like say, don't know if we can actually bring everything that's in that moving truck. So definitely advanced conversations are definitely critical, and give them some expectations of what actually can fit into the room with their support. So
I think
the
that's
floor plan is exactly
yeah.
what I was going to say. That coupled with the checklist and doing it together, will this fit? Even providing some examples of what kinds of furniture people are seeing in there. That's key.
One key thing, just I'll add to the size of the bed. If somebody's been sleeping at home on a king or queen size bed, and now they're moving into a community that can only support a twin bed, that's a big shift for some people. And if you're used to being able to have space to roll around, or just that comfort level, so even the consideration for a wider twin, if that's the case, is something to keep in mind as well.
Excellent. That's great. And so the next question is, are there resources available for people working in communities who don't necessarily have a design background, but who want to learn about those small changes that could make a big impact within a room?
Yeah, I'll take the lead on that one. I think as we talked about in the last question, having that checklist for move-in could also be really beneficial to the change in condition as well. So as the condition changes, can you go through that checklist again and say, what are there things on this checklist that maybe triggered the resident? It doesn't take a design background, I think, to really work through a furniture layout, or adding a floor mat, or really kind of going into the room with a critical eye and just saying, okay, what is the resident doing? Are they trying to transfer? Okay, is there room to transfer here? So, as much as I would like to be hired for everything and to look at every room, I don't think it's necessary to have a design background to approach that with a critical eye to really see what kind of changes are needed.
Awesome.
Even having the pre-planned floor plan, right? So you could
Mhm.
even just already send them off, already have sales and marketing, already have like the
Yeah,
four
for
different
sure.
options that are already on
Yep.
the floor plan. And you could consult somebody like Erin, in advance and just say, hey, help me draft what the templates kind of
Mhm.
look like. And then from
Yeah.
there, you guys can just kind of be off and running.
Yeah, and if we're designing a community, if we're designing a memory care community, we will already do those furniture layouts, whether we design the rooms, whether we do each individual room or not, we're going to be designing a couple of different iterations of that room. So that is something that we do provide to the communities upon completion, so they have access to those resources as well.
Excellent. Sounds like the information's out there. And so this next question was very specific to that third case study, those 2 still images. Does this need to be coded and reported as a fall, even though on video you can see that the resident did lower herself?
Yeah, great question. When you have the video, our communities are witnessing the event now, so they actually consider being able to watch the video. They are able to witness it, and then if they actually see that the resident just intentionally lowered themselves, it's very clear, and that she was safe. They actually would not categorize that as what we would assume would be an unintentional fall to a lower level. And so you are correct there. They would actually not report that as a fall, which is where Safely You has been really beneficial because in a sense, we've been able to reduce what would have been considered falls, for those residents. And again, unnecessarily sending them out to the ER, right? So those are typically unwitnessed events. And depending on, what the resident might be communicating with you, you might be sending them out to the ER when she was just cued by her shoes, So, yeah.
Surely, I would add to that, and to the person who asked the question as well, making that decision is probably built into your policies and procedures and your organization's approach to those sorts of incidents. And so before you make a change, you'll want to make sure you consult with either your attorney or your if you're part of a corporation, to make sure that your policies align with your practices then too. Like Shirley said, this is giving you new information now. And so it is relevant to go back and revisit, I think, those policies and make that decision together as a team to decide how you're going to approach that, and probably will require some additional education with your staff then too, if you decide to make a practice change.
All of our communities still document that it's still an event as well, because it is still an event for the resident that we want to minimize. So from a documentation perspective, we still want to document every event where the resident is found on the floor.
Mm-hmm. Yeah, and depending on the state, I think you're into, and I know we've been talking in context of senior living, which is regulated at the state level. If we get into skilled nursing, there might be some different, considerations for MDS documentation and other requirements there from a documentation perspective. But again, I think it changes the situation. We have better information now, so it's worth being able to go back and revisit your practices.
Excellent. And so next, do you have any suggested interventions for those wandering residents who continue to fall?
I could probably take this.
Yeah.
We have seen, fall events where the resident that's not the resident's room actually wander into another resident's room and then think that's their bed or whatever, and then they end up falling in that room. And so when we see that, repeatedly, a lot of times the advice is really just, it's about activity, and get them engaged in something that's not that type. Why are they curious in a sense? I mean, you want to actually, promote that type of curiosity, but at the same time, it's how do we kind of cue them into a different type of activity to make sure that you have eyes on that individual, is also something that we've recommended when we've seen repeat falls.
From a design perspective, I think some of the things I've seen on dementia care units is looking at the walking patterns in the community and trying to understand if there's some natural places where people like to stop or congregate, or rethinking like seating areas or creating opportunities for people to sit or even signage sometimes can be a cue as well, if they're trying to get someplace. So I think being able to look at the person holistically and try to understand where they're coming from, what it is that they're seeking, what they're looking to do, and then seeing if there's ways to create some more safety there. It could also be a trigger, a need to look at a therapy evaluation, or maybe an opportunity to reevaluate medication as well. If somebody's feeling dizzy when they get up, or if they're or they get lightheaded as they're walking and maybe exerting themselves a bit and feel like they need to lay down or sit down. Those are things I think that might warrant a medical evaluation or a therapy evaluation to see if there's something else that might be happening.
Good note there. And an excellent transition to our final question, which is, do we have any recommendations on tailoring fall scene investigations specific to a dementia patient or dementia unit?
Yeah, so Safely is all about fall scene investigation, that we can actually rewind and replay it over and over again. And so, for us, we also have another toolkit available, which is called our fall scene investigation checklist. And it helps train, we don't really want staff to always be having to grab a sheet of paper to write down the checklist, but the point is to train your staff to understand what to quickly look for, and that is available. But there's kind of the basics, so when you walk into a fall scene, obviously you want to address the resident needs first, and then of course you want to take a look at the obvious in the room. Where's the mobility aid? What does the lighting look like? Are there any disheveled sheets and bed sheets? What's on the floor around that resident? We have actually learned at Safely U that 30% of falls, the resident actually moves position before care staff actually arrive. So if you can imagine, in Safely U, the care staff arrives within minutes, but that the resident will actually scoot themselves from one place in the room, like maybe at their bedside, and all of a sudden they're just really quick on the floor, and all of a sudden they appear across the room. So when you walk into the room, you actually might think that they were ambulatory and they fell by the dresser, right? So it's really critical to do a fall scene investigation, because 30% of the time, the resident actually might have been in a completely different location. And so it is really important to scan that room, look at kind of the quick things that seem obvious, but also maybe not that obvious, right? And so the mobility aid to us is like really critical, because when care staff do enter the room, and if the mobility is close by, that's the first thing they're going to move out of the way, right? Mm-hmm. They're going to actually disrupt the crime scene, is what we kind of make that equivalent to. They actually disrupt the crime scene and they move the mobility aid, and all of a sudden, an hour later, when your team does the fall huddle, you're like, okay, well, where was the mobility aid? You're like, I have no idea, so because we moved it. Anyway, so we totally believe in having a proper fall scene investigation and really training it to your care staff, and even doing in-services and actually testing them if they set up a fall scene, right? And so Safely U is really big on we have several fall scenes available for community just to do role playing of saying, hey, let's actually have the care staff come into the room, do the fall scene. We really want to make it natural for care staff to do this on their own without that sheet of paper, but it's a great way to start.
Yeah, it's really, I love that. And I love that. I would agree. I think we used to do those role-playing events as well as part of an educational. It can be fun, too, for the staff, and then we would encourage the staff to set them up for each other sometimes too, and getting them involved, because sometimes, they'll come up with things that they've seen, or sometimes it even triggers a thought that they hadn't thought of before, then too, something that they remembered. So yeah, that's a great idea. I have a question, actually, Megan, if it's okay. I wanted to ask Shirley a question, put you on the spot, Shirley. Can you, I recently heard that Safely U is launching Safely U University. So can you tell us a little bit more about that, and what all that means, what that is all about? Sorry.
Yeah, so it kind of leads into why we know so much about fall scene investigation. We're actually, and I also kind of called out in the webinar about fall champions. So Safely U really wants to promote fall champions in every community, and so we've launched Safely U University that is specifically in building a fall champion. What we've designed is actually an education platform to merge fall prevention specifically with dementia care. Typically those type of education sessions are always separate, you know, so your care staff have to go do their 1 hour training on fall prevention and their other 1 hour training of dementia care, but then they never actually talk to each other. And so, which is also why it's been really difficult to solve falls in memory care. And so Safely You has taken all of our lessons learned and actually have done this mashup, you know, in a sense of merging those two type of education sessions and really trying to elevate, again, this fall champion. And so Safely You University does have, it's about an hour to become a fall champion, certified Safely You fall champion. And then you unlock actually all these in-service opportunities, which is what we've kind of called out here right now about the fall scene investigation, for example. You get the toolkit, you get fall scenes of how to reenact some of these. And then we also give you some other things where you could do short in-services to, again, promote within to keep these sessions like exciting, you know, kind of fun and interactive.
That's so cool. I hadn't had a chance to ask you about that yet, and thanks for sharing that. I think that's really great and speaks a lot to, I think, how you're continuing to try to figure out how to make Safely You as, you know, beneficial and part of the care team, really is what it becomes then.
Yeah, and it's free, you know, we want everybody to take it. It's, you know, and it'll actually have CEU credits soon, and we're excited about it.
That's terrific. Great. Thank you for answering that. I appreciate it.
That is exciting stuff. Thank you all. Liz, Aaron, Shirley, I appreciate your time, your expertise, and spending this afternoon with us. Thank you so much.
Thanks, everybody.
Thanks, guys.
Bye.
Bye.